Vamos a tener una sesión que es para compartir y comentar un caso de implante de válvula pulmonar venous. Dr. Cheng Xu, right? Are you listening?
Yeah, here I am.
Okay, thank you very much for joining us. Welcome from
Thank you.
Rio de Janeiro. In the panel with me is Dr. Marcelo Rivarola and Dr. Alejandro Peirone, Rodrigo da Costa, Raul Rossi, maybe I forgot, Marcelo Ribeiro, right? All of them will join us in the comments and discussion of your case. So from now you are on charge. You can begin with your case, Dr. Cheng.
All right, thank you, panels and moderators. So we plan to give us a live case, but there's something happened with the patient family. So we had a recorded case presented here, which is a TPVR case. I will be here presenting my team, Dr. Shang and I, and Dr. Zhang, all the team members. So the patient is a 53-year-old male. He had complete correction of tetralogy of Fallot 40 years ago. In recent 3 years, he had edema of lower limbs. And he had the lab examination, anti-pro-BNP 1,000, above 1,000. And his serum creatine is 104. His diagnosis is pulmonary valve insufficiency, tricuspid valve insufficiency, mild mitral regurgitation. He had NYHA 3 heart function. This is the ECG with rapid atrial fibrillation and with some ST segment change and a complete right bundle branch. Usually we saw that in the postoperative tetralogy of Fallot. His echo result is with enlarged right atrial and right ventricle. His diagnosis of echocardiography is severe pulmonary valve regurgitation, moderate to severe aortic valve insufficiency, and very severe tricuspid valve insufficiency, mild mitral regurgitation. Here we see he had decreased left ventricle ejection fraction at around 40. This is the CT of his pulmonary artery, and we can see he had enlarged the whole pulmonary artery trunk is enlarged, and with some sinus we can see here. And we had some restriction above the valve plane. And we had some summary of CTA image. He had like bicuspid valve, and he had narrowing at 0 to 10 millimeter above the annulus, and there's his LAD is relatively close to the MPA at pretty high above the valve. So usually I think the valve will not tilt towards this plane. So I think the risk of coronary risk is still considered to be low. We had suggested a working position, but we will choose another position due to the reality. So at annulus plan, his average diameter is around 27. And on the RVOT plan, it's around 38. So the plane above the 5 millimeter above the annulus is the narrowest part, is around 26 to 25 to 26. And above 10 millimeter above the annulus, the diameter is 26. And then it enlarges until the bifurcation. Here's the several plan we simulate on the software, but later we will see. The best plan we will see will be better at 101 RL, which we cannot reach. So we choose another position at RAL 70 to see the whole pulmonary artery, and then we place the valve at that plan. We had simulate 2 valves to implant in this in the position. One is P28 and 25. This 25 means the height of the valve is 25, the cylinder part, and this 30 is more than that height. So I think usually we will choose the shorter one because we want the lower part to be more close to the annulus, so it can seal the whole plane here. This is the LPA bifurcation diameter and RPA bifurcation diameter. And this is the length of the 2 plane we measure. That represents the length of the cylinder part of the valve. We want it to be shorter than the distance we measured. We measured twice at 31 and 28. So we think 30 may be too long for this to seal this part, and then we decided to go with the 25 length valve. So based on the overall structure, we decided to prepare 3 valves, 26, 28, 25, both at a cylinder length of 25. So the outflow and the corolla will be anchored at the valve annulus and RVOT. The inflow and the outflow end will be anchored at the bifurcation of the main pulmonary artery. So I will present the case recording. Can you see the screen?
Yes, Shang.
Yeah, okay, I will play the video. So as usual, we will use radio opaque guide wire and to LPA, because this one, the LPA seems to be better direction. And then we use this guide wire to guide our MPA catheter into the far end of the LPA, and we place that MPA.
I'm sorry, Dr. Chen. One question at this moment. At this moment, did you consider the balloon occlusion of the outflow tract? Or sizing balloon?
Balloon?
Yeah.
Yeah, we will use balloon sizing later.
Okay.
Yeah. So we use the TIG catheter to do the coronary angiogram, which also we think the coronary risk is low, but we still need a coronary angiogram to do the to see if we had any oppression of the coronary artery. And then we use Landerquist guide wire to send it to the LPA, which we will work on this guide wire later with the compliant balloon and also the whole system. here's the we use the Abbott AGA balloon, compliant balloon. Make sure our coronary guide wire is in the place. And then we inflate the balloon to see if it's in the place. Now the balloon is fully inflated, and then we give the coronary angiogram. We see there's no obstruction or oppression of coronary artery. The balloon size is 34. And we took it out of the balloon, and then we kind of do some measurement here. So we had two narrowing. The first one is above 29. The second one is around 26, 27. So now we were having a little bit of discussion in our team. I think for this case, usually we would choose the valve above 26, at least 28, because we had narrowing here. The size of the balloon shows that the narrowing here is above 26.
Yeah.
But
sorry,
we think
can we
even
discuss a little bit, or you want to keep going? Yeah.
Yeah, you can discuss anytime.
Yesterday we were discussing in detail the tendency, the current tendency that non-compliant, compliant balloon like sizing balloons are not the adequate to measure the right ventricular outflow tract in this kind of patients. Would you consider changing your practice in the future, just measuring the right ventricular outflow tract with non-compliant balloons?
So I think we now our strategy, usually we don't depend on more on the balloon sizing, because usually we were not the RVOT is not the place we anchor our valves. So we only think about the sealing of the valves. That's why later we choose a 26 instead of 28 valve here, which might cause some controversy or discussion later, because we think if we can anchor the valve in the right place without any mobilization, it's safer to choose a smaller valve instead of a bigger valve, because even you have a little bit like paravalvular leak around that part, it will not cause big problem. But if you have oppression on the coronary artery, it's severe complication there.
Also at the very beginning, when we started the experience with venous pay valve, I would like a comment from you, or maybe from Pancho, that the early takeoff of the right pulmonary artery was a problem to this platform. Or Pancho, would you consider that this case maybe has an early takeoff of the right pulmonary artery?
I think for this particular case, either PA branch you choose to pack the wire could be the same. I was more concerned to use the LPA because it has an angled takeoff. However, the angle is not in the takeoff of the LPA. It's a little deeper. So I think at the bifurcation you will have room enough to come from either branch. So let's continue. Shang, tell us which valve size you choose and 26 or
Yeah.
28? 26.
There is no sense.
Our team decided to go with 26 because we were more concerned about the coronary artery, and also I think actually I'm the one who will choose a bigger valve, but later we go with the smaller one.
I would be with you.
Yeah.
Okay, let's see.
So about the route, so usually we will choose the RPA because it gives more a better position and a direction of the valve. But in this one we choose LPA because maybe we didn't show that on the video. For this patient, we would like to lean more against the LPA, so the corolla will be better seated there, and then when we pull a little bit back on the valve will be in the better position. Maybe not, but in this one we choose the LPA instead of RPA.
Okay, great. And I see you are not using a long sheath like dry seal or other. You use the shorter sheath and go with the delivery catheter by itself.
Yeah, actually, the long sheath is not available in our theater. So the only one we have is this kind of shorter sheath. And as you see for this one, it's a little bit hard to push the valve into the right place. And then we gently pull the guide wire, a Lindquist guide wire, and then the whole system goes kind of like gets into this place as you will see.
There you go. I assume that when you work with the delivery catheter by itself, sometimes more frequently than one likes, sometimes it's a hard job to advance the delivery catheter. But I think you have developed some techniques or particular movements to advance. So you demonstrate that. Can you comment maybe on what kind of management of the wire or the delivery you do to deal with this RVUTs? Yeah,
I think this is it's a great question. Actually, sometimes we also met some problem in pushing the whole system to the right place. So the first thing is we will go very deep into the LPA to place our Lindquist, so give us a little bit space to pull it, and then when the system like goes in, if you gently pull the wire, the whole railway will be like more straight, and then it will finally gets into the place. Usually it'll work.
Okay, thank you. Please continue.
Yeah, and so at this moment we push the whole system into, and we think it's already part of the corolla is already near or in the LPA, and then we use the pigtail to do the angiogram to confirm our position, and then we will switch to our working plan. But later, as you will see, this pigtail is below the annulus, and when it goes to the angiogram, it's still not very, very clear, but we can see. This is we use RAL 70, around RAL 73 or something, to show the whole length of the pulmonary and the RVOT. So we will make sure our system is in the right place. And we think our pigtail is a little bit too much into the right ventricle instead of close to the pulmonary artery. So we put the radio opaque guide wire to guide it more into the pulmonary artery. But later, when we release the valve, we will pull it back into the right ventricle, just to make sure we can see the whole main pulmonary artery. Yeah. So this is the position we put the pigtail. And then we begin to release our valve. Here we try to push a little bit our device more into the LPA, because I think if we have the corolla opened, then we can gently pull it to anchor on the restriction plane. Instead of if you put it too low, then you cannot push it back to the position. So we will choose a position which is a little bit deeper than we want it to be. And when the corolla is fully, nearly fully open, we will do the angiogram to make sure our position. As you can see, part of the corolla is still restricted in LPA. Then we do the angiogram. As we see, this is a little bit higher than we want it to be. So then we gently pull the device and begin to continue to release the valve. After this angiogram, we think the position is good here. And then we pull the pigtail down to the right ventricle and then begin to release the whole valve. So I think this is the final position. And then we release, we begin to pull back the tip. Usually at this moment we need to control the guide wire so there's no tangling with the valve. The tip will not tangling with the valve.
In the meantime, you advance the video. In the meantime, do you have any particular preference about the projection to work, or you rely on the previous CT scan evaluation to select a particular projection?
So when we were releasing the valve, we will use just this projection because we had more experience with the other valves instead of venous P. But and I think this position works us very well. We didn't see any problem.
Right oblique, right? That is RAO.
Yeah, right oblique around like 60 to 70.
Okay.
Because we can see the whole length of the pulmonary artery.
Yeah, I agree. And this is a good projection. Please continue.
Yeah. So as you see, we withdraw the delivering device, and then we goes in an MPA to withdraw the guide wire, the Landoquist. And then we try to see if we had any oppression on the coronary artery. And in this one, we were pretty sure we were not tangling with that. We still do the coronary angiogram to see if we were in the right one. And the pigtail is in the pulmonary artery. We can do the measurement and the angiogram there. So as you see, we still have some PVL around here. That's why I think 26 might be too smaller, but I think our colleagues is just like too cautious for the coronary artery. And the position is pretty good, as expected. And then we put the thick catheter into the coronary artery to see if there's any entangling with the coronary artery, which show the
Do you always check coronaries after the implantation, or if the patient is clinical good and stable, it's not necessary?
So for venous P, we always do the angiogram, because it still depends on the valve's shape. I think this one, there's still some. I think there's still some radial force on at the main pulmonary artery. So we had several projections which show that there's no oppression of coronary artery. And then we withdraw the catheter, and it's all set.
Great, perfect. A question was a fantastic outcome. Really, very nice. The valve seated there. That small leak that the valve, the paravalvular leak that this valve showed. In your opinion, that is not important. Is small leak. At what point you consider redilating the valve to avoid that?
Yeah, I think for this one, as actually there's some discussion at that moment when we're choosing the valve. I would prefer a bigger valve at 28, but I don't think I would go to 30. But our colleagues think that if there's anything happen to this patient, because he had a LVEF like only 40, so if there's any oppression on the coronary artery, we might have some disaster there. So we decided to go a little bit low I think even there's some paravalvular leak, it should be okay there. Another thing is we had, this patient had like a little bit bicuspid valve. And so I think the bicuspid valve, usually it had long leaflet, which will be surrounding around that cylinder part, which will usually reduce the paravalvular leak.
Great. Pancho, I would like to have your comment about that. Have you had a perivalvular leak with this valve, and how you manage that?
Yes, one comment about that. I think maybe it will be better a bigger valve in this situation, maybe 1 or 2 millimeters more. Yeah, I agree with you that. In some case, I think we had 2 cases. We put the same balloon inside the valve, the same complacent balloon like that you used before, and expand. Sometimes we dilate the valve, and the leak was gone. That is a good idea, because in other case, when you have infolding, we did the same. That is very, very safe, and it's easy to do it. Yeah. And other question is, you don't use the long sheath. When you consider that it's possible to retrieve the valve when you are not comfortable with the position of the valve.
Okay, that's a good question. I had a little bit of comment on the first part, the first question, the first comment you were making. Usually, if the valve is like more a round shape, we will not post-dilate it. Even I know the post-dilate will give us a better sealing at the paravalvular leak. But the thing is that we increase the cylinder diameter, and so the contact of the leaflet might be there's some space in between. Then you just move to a PVL into sometimes. That's why we don't post-dilate this case. And the thing is, for our experience, we had like around 40 to 50 cases experience of TPVR. But for the venous P, we didn't have that much experience, around 10 or something. The thing is, we never met the problem that we need to resheath the valve. But your recommendation is good. If we had a longer sheath, sometimes we can resheath it, or we can retract it back into the, and then we can do other things.
We have 5 more minutes, I think, to questions. So if someone would like to ask some microphone for Raul. Dr. Rossi there. Okay. So in the meantime, prolapsing, the need for retrieve a partially deployed valve is really unusual. Actually, you are right. We have already done about 70 cases in Argentina and Chile, but so at that time of our experience, we had a couple cases of prolapse of a partially deployed valve. So it's good to share experience. The first time we had a prolapse of a partially deployed valve into the proximal RVOT, we were using the short sheath. We are not using long sheath at that time. And it was possible, I tell you, it was possible to pull back the partially deployed valve through the tricuspid valve very gentle, of course, and pushing the wire, so trying to keep align the valve in the middle of the tricuspid. I tell you, if I felt any resistance, I would stop. But the valve goes all the way into the RA and IVC, and there in the IVC, it was possible to retrieve the valve inside of the short sheath. So it's possible, it's risky. I think that is one of the reasons why it's useful to use a long sheath, you name it, the tricycle or axis. Raul.
Thank you.
Thank you, Dr.
So actually, I'm a cardiovascular surgeon, so if I would prefer to research it instead.
That is a plan B. Okay. Here we have a question on the audience.
Thank you, Dr. Shang, for the beautiful case and very nicely done. We here in Brazil haven't the experience. We haven't started with experience with the Venus P because it's not approved yet. We're looking forward to it, but everybody tells us that the coronary arteries are at less risk of compression when you use self-expanding valves. Is that a fact, or you did have problems with coronary compression as well?
For our team, we haven't had this experience of coronary artery, but we heard some story from other centers about the coronary artery oppression, even with the self-expandable valve. So that's why we were more concerned about this, because I think if even we have some kind of like less than moderate PVL, it's okay for the patient, but if we had that disaster, it's totally another story.
Okay, thank you.
I have a question, not of the procedure. However, I saw in the case presentation you include pro-BNP in the workup setup. I mean, that is routine for you to measure level of pro-BNP, because I think I saw a Chinese publication, maybe yours, I don't know, that they use that and they demonstrate that after the replacement of a functional valve, levels of pro-BNP decrease. So is part of the routine to include that exam?
Yeah, for our experience for the TPVR procedure, we always measure, we always have this lab test anti-pro-BNP, and in our experience, it always drops. It always drops. I can't explain why, but it always drops.
Yeah.
I think it's useful, and probably there are several ways that you can demonstrate a functional impact of a revalvulation, clinical or pro-BNP or exercise test with oxygen consumption.
Yeah.
So there are several ways, and we have to do that to demonstrate an impact.
Beneficial, yeah.
I can comment that there is a recent publication 1 year ago from Carol, from that in patients that you don't fulfill all the criteria to pulmonary valve replacement, and you are in doubt, they order a pro-BNP, and is as a biomarker for cardiac insufficiency, and they plot this with outcomes, and an elevated pro-BNP predicts that that patient is going to need a valve replacement in the near future. So if you are not sure that the patient fulfill all the criteria, this is another variable to take into consideration to send the patient for therapy.
Good point.
Thank you.
We are just in time, so we complete the task on time. Thank you very much. Shang.
Thank you.
And thank you very much for sharing your experience and your case. I think it was a good demonstration of this kind of technology. Thank you very much, everyone, and see you.
Thank you.